Today we're here to discuss in-office BPH therapy, proper placement in the BPH treatment pathway. As many of you guys know, I'm also the head of legislative affairs for the AUA and deal with many aspects of health policy. And I just want to bring up right off the bat, everything we're talking about in 2013, no matter what it is, including BPH therapies, deals with value. Remember, value is quality over cost. So the only way we're going to increase value is either have a better quality procedure, drug, whatever it may be, but at the same time try to keep costs under the best control that we can, and thus that increases the value. So right off the bat, one of the things we're going to talk about, because in the past, many people may have thought, well, is there much value to these various procedures? And we're here to discuss with you and tell you, yes, there still is, and there may be even more value in 2013, 14, 15, 16, and beyond compared to the value of these from the past, and we're going to go into detail a little bit more on that. We're going to talk about population issues both in our country and worldwide. And you can see the timeline up top. In 2000, there were 6.1 billion people in the world, about 313 million of them in North America. And remember, North America isn't just the United States. It's the United States, Canada, and Mexico. But you're going to see as the timeline moves in 2020, remember, we're closer to 2020 than we are to 2000. It's at 7.7 billion with 374 million of these now in North America. So you're talking about, again, a huge growing population. And it isn't just growing population where the age is staying stagnant. Our ages are increasing, and our life expectancy is increasing. So, for example, in 2003, we're still expected, if we're at 65 and we're still living, that we're going to live another 18 to 20 years at 65. And at birth in 2003, you were talking somewhere in excess of 80 years old. I just actually saw a recent statistic when I was up in Washington just a few days ago for the JAC meeting that discussed the life expectancy now. If a child is born right now in 2013, the average life expectancy is felt to be 91 years old. Okay? Again, that's a huge chunk of people 65 and older, which we're seeing. And that's not just in the United States, that's in the world that's happening. As you can see with the developed countries on the left and the developing countries on the right, that's the fastest growing segment of the population in the United States. Our 65 and older population is going to double between 2000 and 2030, up to 71 million people. That's a lot of prostates that potentially are going to need to be treated. And we know that as we age, the BPH numbers go up, prostate cancer numbers go up as well, so all prostate diseases. But in terms of our discussions today, we're talking about histologic BPH, and you can see how those numbers dramatically increase as we age. I was fortunate enough to sit on the AUA BPH guidelines panels. You heard about various guidelines in the first lectures this morning at the meeting. Well, we split it up into 4 different real areas. The first being watchful waiting, the second being a number of the medical management or medical therapies that existed and complementary therapies, the third being the minimally invasive treatment options which were available, and the fourth being a variety of surgical therapies. For the discussion today, we're going to mention all of these to some degree, but most of it is going to be in comparison to these minimally invasive therapies. First of all, we have a number of medical management, medical therapy drugs which are available in many different drug classes, and many of us prescribe not just one drug class at one time, but sometimes 2, 3, and up to 4 of them. And all of them have their potential role, but all of them have their potential limitations too. Let's talk about the market a little bit. Again, I'm trying to paint the picture of why these minimally invasive therapy options, such as Prostiva, such as high-energy microwave therapy, may be a growing, I won't say necessarily need, I'm going to say a growing population. It's for you to decide whether you need it and it fits into your scheme of treatment. It fits into mine, and it's going to fit into his. But we're trying to discuss with you why it probably should fit into yours as well. You can see that whether it's in Europe or the United States, that our minimally invasive procedures and surgeries are going to run somewhere around 3%. Some of the differences is that in the United States, we do a little bit more watchful waiting than they do in Europe, and they do a little more drug treatment than we do in the States. Those are the big differences in terms of the markets that we're dealing with. The other issues now for the next few slides is I want to talk to you about cost. Okay, again, we talked about value. Part of value is cost. Well, in the United States, we spend way above the slope of the line in terms of a variety of developed countries, in terms of relative wealth. This comes from a New England Journal article not too long ago in 2009. Some other slides from this particular article show that the expenditures for all of what we're doing, all of it, is significantly greater than the actual expected expenditures. And in terms of the drug and non-durables, you're talking about 2.5 times the amount that really is expected. Okay? These next two graphs, though, I think are really telling. Okay? What you see here is in terms of the total expenditure on health in terms of drugs, we actually don't fall too bad in terms of the United States. There are countries that are a lot higher than we are in terms of percentage of total expenditures in terms of health, but look at this graph. When we look at the per capita, so the per capita dollars, we're way higher than any of the other countries in the developed world, way higher. And that is sometimes because of the drug selection and choices that we make, but we're way higher in terms of our drug costs. Now, this particular schematic and graph I just bring up to you because I'm kind of lumping all of the medical management treatments into one block. And that is that basically if you're going to give some type of medical management, expect that you're going to have a change in symptom score of somewhere around 5 points. Okay? It may be as low as 3.5, it may be as great as 6.5, 7, somewhere in that ballpark, but roughly expect that you're going to get about a 5-point symptom score improvement, and keep that in mind for this talk because that's going to be a baseline number that we want you to keep in your head. Roughly a 5-point symptom score drop from types of medical managements. When you look at some of the minimally invasive therapies, you actually see that there are significant improvements, anywhere from 9 to 11-point drops in the minimally invasive therapies, and the ones that are available today being TUNA and the Targus. You're seeing somewhere in that 10 to 11 range. Now, if you notice, we didn't mention TURP. Well, TURP is down there. TURP is at 14, 15%, somewhere there. For many years, we compared these minimally invasive procedures to TURPs. Are the procedures such as the high energy microwave therapies and the TUNA's or Prostiva's procedure, are they as good as TURP? The answer is no. Okay? It was felt that, well, maybe they are, maybe they're not, and it was marketed to us that, well, instead of doing a TURP, maybe you want to do a minimally invasive treatment. I would state to you that maybe instead of giving long-term medical management, maybe you ought to consider doing a minimally invasive therapy in that patient group. I understand that patient group, as I showed you in the slides before, is a lot larger than the TUR procedure group that we already have going. So a much greater percentage of people may benefit from a minimally invasive procedure rather than chronic medical management. I'm going to give you as well a little bit of some of the rates of interventions of the various treatments. The first one being TUMT, and I will tell you there is significant variability across the country where treatments are done and where treatments are not even done let alone which of the treatments are done. So for example, in the southeast section, you can see there's a pretty nice smattering and scattering of microwave therapies that are done, and you can see in various pockets of the country, there's huge percentages that are done. You also see in a significant number of pockets of the country, there's no procedures that are done. When I do the same thing and I look at the same map for TUNA, again, you see a pretty nice smattering of areas in your section, the southeast section, and pretty heavily weighted a little more down in the Florida area. And again, where you saw the big pocket of microwave therapies, you don't see particularly any TUNA procedures being done in those areas. Now, do we hope as well to educate you today that, you know, guys, if you're thinking about a therapy, you know, maybe at times there may be one minimally invasive therapy that's better than another, and maybe you ought to consider a TUNA over a high-energy microwave therapy? Maybe. Or maybe is there some patients that instead of doing a microwave therapy, you ought to consider the Prostiva instead of the high energy? The answer is yes again, and my partner is going to go through a little bit more of that in his particular slides. So why is it? What are the reasons that for the relatively low and uneven utilization rates of these minimally invasive therapies across the country? Well, let's first go over some over-optimistic early results. Some of them, the early results of certain of these energy sources were single-center, non-controlled studies. However, when we looked at it versus outcome of multi-center controlled studies, boy, some of them significantly fell out of favor. I'll give you examples of it. The initial, as many of you remember, back in the mid-90s with the hyperthermia BPH trials at a single center, you saw significant improvements in symptom scores at a year out and flow rates a year out. But as we know, by about 1997, this completely fell out of favor because it didn't work. When multi-center trials and things were looked at, and it fell out of favor. Well, that also clouded the picture for many other minimally invasive therapies, because initially, again, you only get one shot at making a first impression, and initially for many of these individuals, boy, they already soured on many of these to begin with. Let's look at some other ones. Difficulties in operationalizing the office-based aspect of these treatment without causing pain to patients. Boy, a lot of the early therapies that we did, they hurt. They hurt people. It was uncomfortable for people. We didn't know how to prep them very well for the procedures. We didn't know how to make them comfortable during the procedure, what tricks we had, what tricks we didn't have. And again, when you had an awake, miserable patient on your table for half an hour to an hour, whatever it may have been, some of the early treatments, that soured us to using many of these modalities. In terms of, and again, my partner is going to talk about that and how we've definitely, our past knowledge and what we're doing today is dramatically different than what it was in the past. We had difficulties in finding the right patients, those most likely to respond to treatment. Again, I talked to you that many patients that probably would have best benefited for TURs, we were doing some of the minimally invasive therapies and didn't have the greatest outcomes on. Number two is that we didn't know which minimally invasive therapy may have been the best option, and maybe we gave a low energy microwave treatment, and maybe a high energy microwave treatment was better, or a TUNA or whatever procedure was better. And again, you're going to learn that as time has gone on, our devices have gotten better, and we've made a lot of improvements in terms of how our energy is delivered and the amount of energy that's delivered, and Bob's going to talk about that. In terms of proxy outcomes, which did not translate into lasting improvement, I just gave you examples of that. And then the last thing is, you know, there were a lot of marketing pitches that were given to you from, boy, oh boy, you can see it. We clearly demonstrated all this tissue necrosis. Well, that's great. Or even Urologix did it. Boy, look at the gadolinium look on this, and just a week after on an MRI. But you know something? That didn't necessarily translate or correlate into patient outcomes. Okay? They were great pitches, but what stands the test of time are studies which are well done of a significant duration that says, do we benefit this patient or do we not benefit this patient? And that's what we now have increasing data that says, yes, in certain technologies, such as high-energy microwave therapy and Prostiva, yes, we are able to benefit patients. Okay? And again, suspicion of high rates of retreatments driving up costs. Okay? I don't care whether you're the Blues or United or whatever it may be, or CMS for that example, and Medicare and Medicaid, you don't want to keep having a retreatment year after year after year after year. And we did that. Okay? The earliest treatments that we had lousy retreatment rates. And remember, these were low energy systems at that time. And we thought that maybe low energy systems were maybe going to be better because they were going to be better tolerated and our patients wouldn't hate us for necessarily doing a treatment. But you can see our outcomes weren't as good. So, for example, I was an early prostatron user and did a number of the 2.0 treatments. This isn't my particular data, but you can see at 1, 2, 4 years, you're talking at 4 years out, more than half the patients needed to be retreated. Okay? In my particular hands, I had 42%. So I fall right into that, but I was 42% at 3 years. So I fall right in the middle of exactly where this group released their information. The early Targus treatments as well weren't so hot, the lower energy Targuses. You were talking about a 29% 5-year retreatment rate. That's still 1 out of 3. I'm sorry, at the Cleveland Clinic, I can't have a 1 out of 3 retreatment rate or that's not just going to be good enough for my institution. But what you do see is that the higher energy devices, big difference between 4 years of 52% and 15%. Now, granted, that's only 12 patients, but this isn't. This was 66 patients. Lance Minders from the Mayo Clinic and the other co-investigators in his group, all very first-class BPH experts in the field. This is quality data. You went from 29% to 9%. So what does that tell me of inference? That tells me that A, we do a hell of a lot better with our high energy treatments now than we did in the past. Now, I want to bring one more up. There are a couple of low energy treatment devices which are still currently available. I would love to be able to show you their data, but I don't have any data at all from 2 years out, period, from any of the devices which are available. There's none. So while I would love to show you, I can't. So all that we can infer, though, is that the high-energy treatments do much better than our low-energy treatments. Now, can we address these common concerns? Well, we just went through a number of each of these. I hope we've addressed some of these, and now we're going to talk about the BPH treatment practices that we have, just in the United States now. About 28% of men in the United States have moderate to severe BPH, and about 11 million of them suffer from significant LUTs. Of those 11 million, you're going to see that 6.2 million have the triumvirate, or whatever you want to call it, moderate to severe symptoms of greater than 7, a prostate volume of at least 30 grams, and a Qmax of less than 15. So that's our patient population that we're dealing with. In terms of 4.9 million of the 11 million have lower urinary tract symptoms, but small prostates, with, again, BPH-related type symptoms. So you're still talking, again, there's significant overlap. So you got to, again, work up, find out who is going to be the best patient population for treatment and who, because of bladder issues, may not be. Again, Bob's going to go through that again in his part of the talk. But our paradigm basically is, again, 96% of patients in the United States currently are on chronic medical management. And we're proceeding, the procedures that we have, about 4% of those were treated with procedures. Again, the most common procedure was TUR. Okay? So again, you got to find your proper patient population that you're dealing with. Well, Medtronic back about 5 years ago conducted a study, an independent study, may I add, that showed that about only 50% of Flomax users, and again, Tamsulosin or Flomax at that time was by far considered because of side effect profiles and different things, probably the best of the alpha blockers out in 2007, but only 50% were satisfied with the effectiveness of their medication. Okay? It doesn't work in everybody. 61% of patients stated that, sure, they would love to have potentially an in-office procedure, and 77% of them said they were at least interested in learning more about it and talking about it. So if 4 out of 5 of our BPH patients want to at least talk about it, I think we owe it to them to at least talk about it. What are the arguments as well against medical therapies? Again, well, half of them don't clinically improve. A number of them, about 1 out of 6 patients or whatever, are going to discontinue their therapy within the first year because of lack of efficacy or side effects. And remember, less than half of our patients do what we tell them to do. Take a medicine every single day. Take it a half an hour to your largest meal of the day. Do what it is. Less than 40%, or about 40% of patients are compliant with how we tell them to take the drugs. They have side effects of fatigue, headache, dizziness, erectile dysfunction, as well as they can mask a little bit of the disease progression, worsening of post-void residual values, decreasing compliance to the bladder, worsening renal function, stone formation, hematuria. A lot of these drugs may hide some of that progression, as well as the fact that these things aren't cheap and they're only going up in price. Okay? So you're talking about $1,700 a year at the most recent numbers that we could accumulate for combination therapy. The cost for Jalen was $1,500, but understand that that doesn't include the fact, and many times, that because it's 2 different drugs, your prescription plan may make you pay 2 different copays. Because even though it's 1 pill, it's 2 different drugs, and many of them make you pay 2 copays. And these costs are continuing to rise over time. In fact, this is an example of one of the costs. This was by Michael Naslin out of Maryland. And this was just looking at Prostiva, but you see that at 2 years and 7 months, the costs actually crossed. I'm actually involved in and it is not published yet. We're working on publication of the cost, but you're talking about exactly somewhere around 3 years. The cost curves are through a Markov model, which we're looking at and using, but our cost curves are crossing. And again, if that's the case, boy, we're saving insurance companies, we're saving CMS, we're saving us, because remember, we're the taxpayers that pay CMS, that years 4 and 5 and 6 and 7, we may be getting a significant cost benefit. Again, remember I told you, what's value? Value is quality over cost. And again, you can see that the slopes of the line also are significantly different whether you had a Prostiva or whether you had any of the drugs or combinations of the drugs. Now we're going to change roles a little bit, and Bob's going to talk about BPH in-office therapy and give you a clinical review and his large personal experience as well in using these devices. Bob?
Thanks, Jim. Good afternoon. I'm Bob Pugash, a urologist in private practice in Southern California. And as I look out on the room right now, I don't know what type of practice you're in. Some of you probably are in small private practices. Some of you may be in large groups. Some of you may be doing fee-for-service medicine. Some may be under some capitation agreement. But Jim's point about value is an important one, because whatever the reimbursement system is that you or your group are getting, whatever the population changes are in the future that are significant, as Jim pointed out, more and more we're going to be looked upon by the payers as individuals who have to deliver value for what they're paying. And there's going to be tighter and tighter amounts of money available over time. So our challenge as practitioners in whatever mode of practice we're in is to deliver that value. So I want to share with you some of my personal experiences with minimally invasive therapies, which I've been doing now for close to 15 years. If you look at the evolution over time, what we've essentially seen is minimally invasive therapies have gone from low energy to high energy. And that's been a significant change, and that's given us the ability today to stand before you and say that the therapies that we have in 2013 are markedly different than what we had 15 years ago. They deliver better outcomes for more time, patients are more comfortable during the procedures, and quite frankly, call you up less at night afterwards. The evolution from cooled or low-energy therapy to high has taken a while. Thermatrix, which was actually a European device that was developed back in the mid-1980s, was a very low-energy device, and it gave you great initial results. And the reason that it did that was it basically gave you a mechanical Flomax effect or an alpha effect. What it did was it burned the nerve fibers, so you had a good result for a while until that regenerated over the next couple of years. So by years 3 and 4, most patients were seeking some type of treatment again. Pro-Li was sort of an intermediate therapy, but again, not terribly hot. And what we've evolved to now is what's called cooled thermotherapy, or CTT, where we generate interstitial temperatures in the prostate just below 70 degrees centigrade. What that translates to for you and your patients is better tissue necrosis, a larger cavity that forms, and a longer duration of outcome. We've also done something else over time, those of us that have been able to work with the manufacturers like Urologix on their equipment, and that is to get better cooling of the urethra. In the early days, urethral temperatures went as high as 44.4 degrees centigrade. That actually was the safety limit of the machine. It would shut off at that point. If you're not under a general anesthetic or spinal and your urethral temperature is 44 degrees, you are not a happy person. You're not happy at 43 or 42 either. Around 39 to 40 degrees is where you really start feeling it. So one of the things that we've done now is to increase the cooling so patients do not have significant discomfort or pain during the procedure, number one. Number two, there is less swelling afterwards. So the incidence of needing a catheter is less, and the time to the period when patients start seeing clinical improvement has dropped dramatically. We used to tell patients it would be 6 to 8 weeks before they'd start seeing changes. I typically tell them now 2 to 3 weeks. The other procedure that we're going to talk about today is Prostiva, or TUNA, where instead of using a single microwave antenna to heat a large area of the prostate consistently for 28.5 minutes, we target different parts of the prostate. We treat each area for 2 minutes and 20 seconds at a temperature of 115 degrees centigrade. Some of us in the room do primarily microwave procedures. Some of us do primarily Prostiva procedures. I would suggest to you that these are complementary technologies, and what I want to try and show you is when you want to choose one over the other so you can integrate both successfully into your practice for the betterment of your patients. Now, looking at data that Jim had talked about before in a slightly different way, if we look at symptom score improvement with medications, we're looking roughly at a 4 to 5 point drop in symptom scores. If you use combination therapy, it's a little bit better. If you use an office treatment, you're looking at a drop in symptom score of about 50 to 100% more. And once again, as Jim said earlier, they're not as good as a TURP. But the issue is not whether you should do a TURP versus a minimally invasive procedure. The issue is, should you be doing a TURP, should you be doing minimally invasive versus a medication. And I think data like this is pretty compelling, as is looking at flow rates. And again, if we look at medications, for alpha blockers and the 5 ARIs, about 1.5 to 2 cc's per second. In fact, I would invite you tonight, go online and look at the PDR when you're back in your office. If you still use the paper version, open it up and look at the FDA submission data that's in there for Avidart. And what you'll see is the average flow rate increase was 1.9 cc's. Now, as urologists, I don't think that's a number that we're comfortable with. I'm certainly not comfortable with increasing a flow rate by less than 2 cc's. If a primary care wants to do that and call it success, they can do that. I think we need to have a little higher goal here, which I believe we can achieve when we do minimally invasive office-based treatments. And again, we'll do better with a TURP, but do we really need to do a TURP in most individuals? So now let's talk a little bit about patient selection, because this is not just the development of low-energy microwave to high-energy microwave. It's also Prostiva and the evolution of Prostiva over time. And so I want to try and show you now where you can use this in your practice, which patients you can use this in successfully, how to make it work well for them. Since 1998, when I started doing these, as of the close of 2012, I've done a little bit north of 800 procedures, microwave procedures, and a little bit less than 300 Prostiva and TUNA procedures. My overall retreatment rate now, from the inception of therapy, is 18% for microwave. It is 6% for Prostiva. And I will tell you that the patients that I'm treating now, or have been treating for the past 6 years with the latest version of microwave equipment, have significantly lower retreatment rates, as Jim pointed out in his slides also. The hotter temperatures that we get now, the better urethral cooling, are translating to treatments that patients tolerate much better, so we can get more heat into that prostate and give them a better long-term result. So how are you going to choose your patients? Well, you're going to choose them the way you would choose a patient for any type of therapy if they have lower urinary tract symptoms. Are these irritative symptoms? Are they obstructive? What's the bladder function like? How large is the prostate is a very important issue when we're looking at minimally invasive therapies. Is it large enough? Is it large enough for any of those therapies? Is it too small for one? You have to make those determinations ahead of time. It's a slightly different thought process. Does your patient tolerate office procedures well? I will tell you that if your patient is halfway out the door when you show him what a cystoscope looks like, he is probably not going to be lying still when you try and do the procedure in your office. So someone who is very sensitive is probably not your best candidate. Your patients have significant medical comorbidities. If they've got really bad coronary artery disease and are taking their nitroglycerin not infrequently, do you really want to do something that potentially is going to cause them some discomfort or pain, bump up their blood pressure while you were there with your office nurse in your office? Probably not. How far has the disease progressed? Is doing anything to reduce the size of that prostate going to make a difference in a patient who comes to you with a 2,500 cc residual? Probably not. So we just want to see if these are appropriate patients or not. So your ideal patient, moderate to severe voiding symptoms, patients who either don't want medication or aren't doing well on medication, patients who can have surgery or are reluctant to have surgery. I'm going to stop for a second and talk about medication here. I trained in the 1980s, and that's when alpha blockers started coming into their vogue, into the mainstream of urology practice. And in those days, the choice was nothing or a TURP. And all of a sudden, we had alpha blockers. We had dibenzoline, one of the early ones, and others that came up over time. When the choice was medication versus a TURP, I fully understood that medication was something I wanted to offer my patients. I think the choice is different now. And I think it's not medication versus a TURP. For me, it's medication versus a procedure in the office that will give me results that are 50 to 100% better than medication. And I can offer that to my patients in a 30-minute treatment. And I can give them results that are durable based upon data that's now available. And do I really want to be giving them medication? I will tell you a story about a primary care physician who sends a number of patients to me. His referrals to me started a few years ago. And I called him up one day. We actually had, we got together for lunch after that. And I said, how come, just curious, why are you sending patients now? He said, frankly, I was tired of sending my patients to another urologist who would either double my dose of Flomax or add, in those days, Proscar, or now Avodart. He said, I can do that. I want you to do something for them, and you're able to do things for them in the office where they're not going into the OR. They're coming back happy. That makes me look good. My patients are happy. That's why you get my patients. If you look at the number of prescriptions that we write for these meds, it's staggering. And that's why the treatment paradigm that Jim showed is what it is, where most patients are getting medication. The question is, how well are they really doing? So we need to use some tools to help us understand how well they're doing. And the first is an AUA symptom score. I assume most of us are using those. If you're not, I strongly recommend that you do it, not just when they first come in your office, but if you want to put them on a medication, have them fill it out the next time they come in. If you want to put them on do a minimally invasive therapy, have them fill it out the next time they come in after that. And the same thing with any surgical procedure. And do it every year or however often you see them to watch over time. It's a fabulous tool. It's a great instrument. I'll do a basic evaluation. I'll do a UA and an exam. I still believe in PSA, mea culpa, but I think it's a good test. I like to know residual urines in these patients because I do so many minimally invasive therapies. I want to know what the residual is so I can tell that patient, is it likely they're going to need a catheter afterwards? In my hands, when I do microwave procedures, 30% of my patients get catheters afterwards, 70% do not. I want to have a rough idea what group that patient's going to be, and just to give him appropriate expectations. I like uroflows. Everybody gets a cysto beforehand. I want to see that prostate, and you'll see why in just a moment, but visualization of that prostate is important before you do that procedure. I don't do urodynamics in too many folks, but every so often, for appropriate reasons, I'll do that. Everybody gets an ultrasound. You have got to know the size of that prostate. If you're considering a Prostiva procedure, you want to know the transverse dimensions. If you're going to be doing a microwave procedure, you have to know the sagittal dimension. Why? Because there are several different length microwave antenna catheters available today. We've gone from the old days where one size was supposed to fit all to ones that we have now in 3 different lengths, so you want to know what the length is to have the right equipment on hand. These are not inexpensive items to keep in your office, so you want to just know ahead of time so you can order the stuff from your representative. How do you choose CTT or a microwave procedure versus TUNA or a Prostiva procedure? Well, both of them are indicated for prostates that are roughly 20 to 50 grams in size. But in addition, a microwave procedure is also indicated for prostates that are up to 100 grams in size, and there's no down limit. So there's a broader indication for a microwave procedure. If you're looking at radiofrequency procedures, you also would consider that for a very asymmetrical prostate, where you don't want to deliver the same amount of energy all throughout the prostate. You want to target different areas. A very short prostatic urethra is ideal for Prostiva. Patients with median lobes that are not these large ones into the bladder that are causing a ball valve mechanism. Now you're going to do a procedure in your office. You've decided you want to try this out. I will tell you this is a very different experience than what you're used to in the hospital. When we go into the hospital, we're used to certain things. We're used to having the patient ready when we walk into that room. Someone took that patient in, someone did the pre-op teaching, somebody took them to the pre-op area, someone brings them into the OR, someone preps and drapes them and says, "Doctor, your case is ready." We walk in and do our case. It's not that way in your office. It can be, but it's your personnel that are doing it. You've got to have your staff prepped to know how to do this sort of stuff. Your staff has to know how to talk to those patients beforehand. Your staff has to know how to talk to the patients afterwards, and to know everything in between, to get that room ready, to get the equipment ready for you so you can walk into that room and do that procedure. Your patients have to be told what they're going to feel. They're going to feel more than if they have a general anesthetic. Tell them that. Your staff can do that. This is really, really important. And the folks that you work with, if you're using like the Urologix products, their reps are fabulous at getting you through this process. We put some lidocaine, we give patients, half a milligram to a milligram of Ativan before the procedure. We'll put some aqueous lidocaine in the bladder, and we'll use some intraurethral lidocaine. Those stay in for about 30 minutes. I do a prostate block on everybody. You need to do a prostate block. If you're not doing them now, you should be doing it. You should be doing it for lots of reasons. Your patients who are having biopsies will love you for doing that because they won't feel anything. If they're doing these procedures, you need to do a block. It will take you all of 60 seconds once you get the technique down. I inject 5 different areas on each side. It literally takes 1 minute to do that whole thing. I don't use anticholinergics. I used to. I've tried sublingual Levsin. I've tried B&O suppositories. I've tried every oral medication that's out there for patients. If patients have a lot of urgency before the procedure, they're going to have a lot of urgency during the procedure, and you can't stop it. There's no way to stop it yet that I've figured out anyway. By all means, try things, but I don't think it's going to make a big difference. Know that if your patients have urgency beforehand, they're going to be a challenge, and we'll talk about that in just a moment. Don't underestimate power of conversation and distracting your patients. In my office, we have a flat screen TV on the ceiling, and we give them a channel surfer like this, and they play with channels and find what they want to watch, and we talk to them. My nurses are fabulous at finding out every single thing about our patients. The patients really do well when they are distracted. If they are focused on that procedure and nothing else, they're going to feel more. What was that study where it said if a guy's having cystoscopy, if they watched on the screen with you, their pain perception is 60% less than if they don't? Same thing is true here. Pain level in my office averages a 3. If patients are starting the ramp-up period, we're getting increased power into that prostate, start talking to them. As time goes on, their perception of pain will decrease. There are some reasons for that in terms of some of the physiologic changes that occur during the procedure, but by and large, it gets less painful as the procedure goes on. What do you look out for? Like I said, patients who are at the door when you show them that cystoscope are not going to do terribly well. Patients who have urgency are a problem. Please don't do your first half dozen patients if they have a lot of urgency. Don't choose urgency, patients with urgency for that. Why? They're going to have more urgency during the procedure, and they may have a lot of it, and you may have to stop the procedure. It can be that bad. You also might want to choose Prostiva over microwave. For those of you who are wedded to microwaves, consider Prostiva here. Because with a microwave procedure for 28.5 minutes, we're heating that entire prostate, and they are uncomfortable if they have urgency beforehand. With a Prostiva, it's different. When you're right at the bladder neck doing those creating those first 2 or 3 lesions, they're going to feel some urgency. But once you pull back from the bladder neck, they don't feel that nearly as much. They'll feel some warmth. So Prostiva in those patients may work much better. So with that, I'm going to stop and ask if you have any questions for Jim and I. There are microphones in the center of the room if you'd like to ask any questions.
How does it look when you do a cystoscopy after you do the procedure?
It's a fabulous question because in the early days, when those urethral temperatures were over 40, and we told patients, oh yeah, you'll urinate in the next week, in the next week, in the next week. It was kind of like the original VLAP lasers we used to do where you told patients the tissue would slough and it didn't. So after a month or 6 weeks, we'd look inside and those urethras were as white as the napkin in front of you. We were overheating those urethras. I don't do a lot of cystos today because I don't need to, but early on I did a couple just to see. There's a little bit of erythema, but you don't see, and that's about a week and a half, 2 weeks after the procedure, but you don't see the pale color that we used to. And if I scope them, years later for whatever reason, it looks like a normal urethra to me.
You talked about a 6% retreatment rate of 5 years. What percentage are back on alpha blockers or 5-alpha reductase inhibitors?
It's actually, for Prostiva, it's 6% since we started doing them. All right, so it goes way back in time. I would, in my practice right now, less than 5% of my patients take alpha blockers.
What criteria do you use to place a Foley afterwards? And secondly, have you used temporary stents and do you keep them on alpha blockers post-treatment?
If their residual before treatment is over 250, they're going to get a catheter. If it's less than that and their flow is reasonable, 10, 15 cc's, something in that range beforehand, we keep them in the office. We hydrate them. And if they can void with a reasonable stream, we send them home. Most of the time, we're right. The other day, I was wrong in somebody who called up at 1 in the morning and was stopped up, went to the ER. There are guys who catheterize everybody. So I just think that most of the time you don't need to do that. For microwave, for Prostiva, everybody gets a catheter. That heat gives so much swelling you can't get away with that. I don't care whether it's a big or small prostate. I forgot the second one.
Temporary stents.
I used to use temporary stents. They're just off my radar. I was doing the spanner for a while. I think they're great. And lastly, I keep them on alpha blockers for 6 weeks. How do we do prostate block? Left lateral decubitus position. You're looking at a sagittal view. You're going to rotate down so you see that little triangle between the prostate and the seminal vesicles. And just go right. I'll go right in the center of that. I'll inject 3 different levels through the same hole. Then I'll make a second piercing and go a little more posteriorly, and then one more right next to the prostate. Some people in the past have actually injected the prostate. I don't think that makes a difference. I know guys who have gone just under the capsule and tried to get things laterally and posteriorly. I don't think that makes a difference. I inject 5 cc's of 2% lidocaine on each side.
Identical as well, same thing. You know, Jones et al. would be the resource or whatever if you're looking for a publication to review. Steve Jones et al.
I was just wondering if you did it any different way than I did.
Yeah, no, that's the same way you do your prostate biopsies. Great. Well, we're going to stick around for a few minutes if you do have questions. Again, we want to thank you all for coming. We we hope you got something out of it, and at least again, we're not up here dictating or telling you to do it. All we can ask you to do is at least consider it and discuss it with your patients. Thank you again for attending.